that during the presentation, nearly half an hour ago, I thought you could not find it, but anyway, now we are over. First of all, I would like to offer my profound gratitude to the conference organizers for inviting me to this scientific session. I can imagine the hard work put in by the whole team, but it is even harder to spear at such an event. So congratulations to the principal GMC, Professor Grover, Vice Principal, Professor Shadar, and the organizing committee for pulling off such a marvelous achievement. I stand here today to talk about a very tedious topic, that is the evolution of neurocritical care and how a neurosurgeon can play a lead role in it. As we progress through the talk, I will also shed light on what propelled me to this cause and also what were the difficulties encountered during the course of this whole proceeding. It is also very important that you really get stoked and goaded continually, because this would then push you towards your objective and you can then attain it, what others really might consider as a rabbi. And to be honest, neurocritical care is a super demanding job without any glorification. So I thought that I would take a glance by peeking in the history and first utilize those ideologues who dedicated their life selflessly to this cause, and then subsequently build a case for our younger generation. We have a lot of them sitting over here, and we put forward this case so that they develop and become the flag bearers of neurocritical care and work for the ailing humanity. Sir Isaac Newton once said that if I have looked further, it has been by standing on the shoulders of the giants. You see, physicians are very fond of having fathers of medicines, but neurocritical care only had its evolutionary process. How did it start? Neurocritical care actually came out of neurosurgery. Although it is very difficult to point the origins, but it can be pointed to these two immortal names, Sir Harvey Cushing and Professor Ward Dent. The former was known to have punctilious methods of delivery of treatment, and the latter is credited, Ward Dent is credited with the first neuroscience ICU in Johns Hopkins in 1932. But things are not that simple, because the critically ill patients were really transferred to special wards which were called as ICU. And obviously I'm talking about a century ago. But patients, the care of the patients who were suffering from head injury or spinal injury was not well developed. And sadly, the decision was left to whether the patient was salvageable or not. Well, men who generated spark, which served as the catalyst for the development of neurocritical care, were nevertheless unrelated to neurosurgery. Bjorn Ibsen, an anesthesiologist, and Thomas Straub, a physiological chemist, teamed up with Alexander Larson, professor of epidemiology, the Apache score, which actually justifies the continuation or de-escalation of the care. The history of critical care would be incomplete if I do not mention the names of Donald Monroe and Sir Ludwig Guttmann, because they developed and pioneered the concepts of spinal cord injury parallel to the management of the head injury which was going on, and they developed units in UK in 1934, 1936 and 1944, and this actually gave a lot of boost to the care of spinal injury management. So although there have been several turning points in the history of critical care, I've only briefly told about personalities and their influence on this nascent specialty. If I were to summarize the milestones of neurocritical care, the first neurosurgical ICU was set up in 1932. Spinal cord units came up in 1936 and 34. But the crucial event, which actually turned the critical care management into something really brilliant, it was the use of positive pressure ventilation devices, these iron lungs, and these were developed in 1952-53 during the polio crisis, and they were spread in Denmark and in the surrounding areas. The consolidation of all these efforts into neurocritical care emerged on the scene when in 1985, American called for board certification started into specialty certificate, but the efforts could not be a success. Modern neurocritical care as we recognize it today started in the 1980s. The first protocols, they started coming in 1996, and the Critical Care Society was formed in 2002. It got recognized as a specialty in 2005, and now it has progressed on to the multimodal neurocritical care. There has been a phenomenal progress made in the care of critically ill patients, but there are few difficulties and complexities. The term neurocritical care arouses hostilities even in countries with very well developed state-of-the-art facilities. The turf war goes on between the various partner specialities. Now, if in countries where the critical care is, I know it's a very difficult subject to absorb, but as a neurosurgeon, I thought that it is very important, pertinent on my part, that we should highlight the role how a neurosurgeon can be of importance in developing the critical care. Now, we all know that there are three different models of ICU care: an open, a transitional, and a closed one. It has been shown that with a closed model, you can substantially reduce the mortality and morbidity. And studies have even shown, cohort studies have shown, that even following the SNPs can reduce the mortality and can improve the patient outcome. Now, as I talked previously, that there are problems in the developing world in the emergence of critical care. We were running a big department by any standards, an absent neurology department, and having an evasive rather than an obligatory attitude of the partner specialities, we had a lot of challenge. So we had only two choices: either give up and be a part of the system, or take up the challenge and develop own neurocritical care. And this is why I say what is the lead role of a neurosurgeon in developing the critical care. So this is how we took up the challenge, and we present our model of closed ICU driven, neurosurgical, driven by the neurosurgical team. And the corollary to this commitment is a TBI-centered neurocritical care with the capacity and capability to deal with all kinds of neurological illnesses. Our main emphasis was on TBI. We diverted our major energies to the neurocritical care modernization and got it flexibly and lightly linked to the partner specialities with the single aim to provide the best care to our severely ill patients. During the course of development, we also adopted the modern neuromonitoring as well. Now we have developed our own organizational structure, replacing the intensivist with the neurosurgeon in a lead role. We all know that there are two challenges to be tackled when we consider the duration and on-call modular structure. One is the continuity of the care, and the other is the burnout syndrome. Usually, the average duration of stay of a critical ill patient in ICU is 2 to 3 days. It is extended to nearly a week or more in cases of multi-organ failure. But the unique challenge faced by the ICU staff is in patients of severe head injury, where the patient is comatose and needs extended support for breathing. Now, this overstretches an already limited staff. This leads to the typical fatigue of a consultant and that of a resident. We have put the neurosurgeon in the lead role. The house staff comprises of a junior and a senior resident. The consultant has an on-premises and off-premises hours, whereas the slogging is done by the resident for 24 hours a day. They have 1:3 or 1:4 rota, which means that they are bearing the brunt. But the senior consultants, they take daily rounds and revise everything, and this is how the continuity of care is established. As you all know, that neurocritical care has formalized as a specialty only relatively recently. Its dedicated units are far and few, and in a developing country, in a public sector hospital, especially like in our country, there is hardly any service, as it requires the best of everything. Our agenda was a continuous endeavor to modernize neurocritical care and acquire state-of-the-art facilities, for which we occasionally raised and frequently inched to it. This presentation is with the objective to demonstrate the effect of neurocritical care on mortality, and more so, to demonstrate that once you do the legwork, everything falls in line with your objectives. So with this background, we are nearing to what I really want to deliver. Our figures show that progressively we had a decrease in the mortality starting from 47% in 2015 to 2019, it slipped down to 33%. You can see that this is not a plummeting figure. There is just a slide in the fall of these figures. This was the result of the standard medical practices we just followed in our ICUs, and we adopted them. But the real change which made a difference and turned it into a standard neurocritical care was the addition of multimodal monitoring. We started neuromonitoring in 2015 with the blah 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 of SNPs, but the real change occurred on from 2018 when we started adding the ICP monitoring, and then to this we added the ventilators. The multimodal monitoring got a real boost in early 2020 with the inception of brain oxygen tension and intracranial temperature monitoring, and finally brain microdialysis. I've been sent that the time is ended, but this, since I thought was a very important topic from the neurosurgery point of view, I should highlight what we have been doing right now. So, just these 3 slides and I will enter into details. Now we do an intraparenchymal monitoring with these catheters in these patients. As you can see, this is the transducer which is put into the brain in a patient where we want to monitor, and you can see the ICP is raised. This is a different wave pattern which shows that it has jumped from the normal 15 to 34 in this particular case, and the ICP waveform trend shows that since it is high, therefore we infuse mannitol. Now this is the right method of infusing mannitol when you know that the ICP is high, and it starts to go down, and you can see the plus 33 is now started plummeting down to the normal range. But then we find that it's not working, it's become refractory. What we do? We perform a decompressive craniotomy, which is the last resort. And then we open up the dura. After performing the craniotomy and the brain pumps out, you can see that the ICP has come down to 6.6, so it just plummeted. Now this is a scan of a patient of severe traumatic brain injury. You know, just see the difference, how the difference is made with the help of multimodal monitoring. And we decide to do the ICP monitoring, the brain tissue oxygen monitoring, and the brain temperature monitoring. This is the usual place we put in our catheter. This is the ICP temperature and brain tissue oxygen monitoring catheter being introduced into the brain. Which is then connected to the joint cable. And you can see the various readings which show that the ICP almost 16, the oxygen, brain tissue oxygen is very low. These are the abnormal graph patterns depicting the waist tension. Now we introduced a catheter into the brain for the brain microdialysis, which is a new concept in the region. And the overall picture given to us shows that the oxygen, you can see the brain tissue oxygen is just 16. And simply by transfusing and giving the packed cells, you can bring it up to the normal. This is the normal brain oxygen tension. And the third thing, which we added to our multimodal monitoring and neurocritical care, this is very important. One of our main roadblocks in the efficient delivery of chest care was the absence of non-invasive treatment for VAP and other pulmonary infections. I would say this served as the main catalyst in the quest to further develop our critical care. We introduced bronchoscopy in our critical care some 3 years ago, and then this was being offered for every patient who required it. It not only served as a therapeutic tool, but also served as a diagnostic tool as well. And just the senior registrar, find the difference. This is very important. Then if you want to do bronchoscopy for an obstructive lung disease, you have to go to your pulmonology colleagues, wait for a few hours to a couple of days time before they can intervene. But in this case, my senior registrar or the senior resident would just shove in the bronchoscope and do the required thing. So I will highlight with a couple of cases how this helps in saving lives. Now if you see, this is just an X-ray chest of a patient which shows a normal appearing lung. It is the second day of traumatic brain injury being ventilated, but when we put in a scope, and as we proceed, we find the transformation which has been done within the bronchial tube. You see these plugs. They are not evident on a normal X-ray chest, but this is the second day. And as you proceed down the bronchial tree, you keep on washing it, and you just encounter further mucus plugs, which you need to clear up. You go down further, you further wash them, lavage them, and you see just these plugs. They're not evident. X-ray chest won't give you anything new. But here you see a lot of mucus which is obstructing the patient. It is soiling for bacteria. This is another case where you see a completely non-aerated left lung. And when you put in the scope, you find that it is the thrombus blocking the bronchus, the main bronchus. So gently try to maneuver to take it out. And as you remove, just look at the size of this thrombus. And when you go further down the bronchial tree, you would imagine that what is happening over there. A lot of mucus, a lot of inflammation, perfect for soiling of bacteria. So you start cleaning these areas, the whole of the bronchial tree, and now you have a completely aerated lung, and this gives you an excellent patient recovery. Now, like any other discipline, capacity building of the human resource is really very important. We keep on conducting regular workshops and training sessions for doctors and nurses in order to bring them to the international standards. And finally, why neurocritical care is important? The obvious answer is for the improved outcome of the patient. But to be true, neurocritical care is the neglected field. The reason being it requires a lot of effort, dedication, and selflessness. And let me tell you, there is no personal glorification. So this is one of the most important factors. So in conclusion, despite all these challenges, I wanted to show you the closed model neurocritical care, the service being completely run by the neurosurgeons. Thank you very much.